what thrombolytic agent is used and what is the costing?
Yeah, I think the only thrombolytic agent which is approved in relation to brain or stroke is Actylise, that is RTPA, and the cost will go according to the body weight, but approximately I would say an average Indian person with a 60 kg will require only 150 milligram vial, which will cost you about 45,000 rupees or so. If the person is a little overweight, the cost may go up to about 70,000 because there is another 20 milligram available, so total cost will go to about 70 to 80,000 or so.
A common question asked by family physicians is, there is something called a TIA, transient ischemic attack. When the stroke patient has a TIA, has a hemiparesis, which recovers very fast. If we give such a person thrombolytic therapy, does it harm? And how do we minimize the not giving such a person thrombolytic therapy?
Yeah, I think it's a very important question which is asked. I think the point to remember is the previous definition of TIA used to be the neurological deficit which recovers within 24 hours. Now we know over the last 3 decades or so that TIAs are very short lasting. Most of them recover within about 10 to 15 minutes. Very few go up to 1 hour. So, in order not to miss TIAs, our definition is if a person, you see a person at say 1 hour and he has a fixed deficit, he is no longer a TIA. He definitely has suffered a stroke. Unless he gives you history, in the last 1 hour, every minute has been improved. Then, of course, you will say that it could have been a TIA. So that's the issue. Now, so one doesn't want to give a person with TIA, obviously, because we see involved and the person is already getting glycine, clot is already getting glycine, is improving. There is no point in giving exercise. But the same token, I must warn you that there are now, though improving deficit is considered as a contraindication for thrombolytic therapy, most of the patients who wish to improve later on, if you follow them up, tend to develop new stroke within the first 48 hours or so. So even those who are improving, this is not a benign condition. TIA is no longer considered as a benign condition, and now all over the world there is what is known as ABCD2 score. That is to decide the severity or risk of his getting a stroke within the next 48 hours or next 1 week or 1 month or so. So if you are aged more than 60, you have blood pressure more than 140/90. If C is the cardiac factor, so if he has a cardiac illness or any cardiac illness, coronary artery disease or something, diabetes and the duration. So if the duration of TIA is more than 1 hour and a person is diabetes, then his scoring goes up. So if you have given each 1 point, total score is about 6. Anybody who has more than 3 points in the score has almost 30% chance of developing a stroke within the next 48-24 hours or so. So TIA is also an emergency. You may not require hospitalization if your ABCD2 score is more than 3. I would suggest you hospitalize him, do urgent evaluation so that you decide what are his risk factors, why is he having TIA, and then decide the line of therapy as early as possible. Whether he requires carotid artery surgery, he requires intervention, or does he require anticoagulation because his atrial fibrillation is from embolizing from that. So you need to decide the stroke mechanism and take appropriate step as early as possible in patient with TIA.
Last question here. Often we get patients who wake up with a paralysis. Are these candidates or is the 3 hour gone?
Right. I think that is a very important point. This is the biggest problem we have because about 30 to 40% of strokes are wake up strokes. And once you have wake up stroke, to time the onset of stroke is very difficult. The criteria which we have been laid down is last seen normal. So for example, person has slept at about 11 o'clock and he's got up at 4 o'clock to pass urine. And then he's 7 o'clock when he wakes up, he's found to have stroke, then his time of onset will be considered as 4. And then you have to go on calculate your time duration according to 4 a.m. as the time of onset. So this is the problem. So many of wake up strokes are not good candidates for thrombolytic therapy because you cannot time their onset. So in order to get out this factor, now we have a problem going on with the neuroimaging criteria. So instead of time is a factor, we say physiology in the brain is a factor. And that's the whole new concept which is starting. It is still not approved, but this is where the work is going on.
We go to the second subject, that is migraine. I have given a clinical criteria of migraine in the file that we have, so I'm not going through the clinical presentation or the classic symptoms of migraine. What I'm asking is how to treat an acute episode of migraine. If you ask 15 people present here what they give for headaches of migraine, we'll probably be given 15 different drugs. from you. Is there a consensus? Is there a standard thing? What should we do? Mild, moderate, very severe headache? What do you choose?
I think I start with simple drugs, more or less. I would say that when my prescription goes, those people who have very infrequent migraine, we treat them only on acute therapy. We don't put them on prophylactic therapy. And my advice is to start with only simple drug like combination of domperidone and paracetamol, which is now commercially available. As Tomstat is one of them. So give that and tell them to start as soon as the headache pre-prodrome or pre-starts. That is the time to use this drug. Now, if a person has more severe, then probably I would combine NSAID with triptans. So the triptans which you can combine is the various formats. So you can use naproxen sodium as NSAID and combine it with naratriptan. The three triptans are available in India now. Is rizatriptan, naratriptan and sumatriptan. So naratriptan, sumatriptan or rizatriptan can be combined along with NSAID. And now I think there is a commercially available preparation abroad which combines naproxen and sumatriptan already. So probably same sort of combination is the next thing which we do. Now if he is vomiting too much and cannot tolerate oral medications, then we have other ways of giving sumatriptan, that is nasal sprays available which can be given. My very important point is that when we use triptans, make sure that they take it when the prodrome starts or the aura starts. Once the headache phase starts and if you use triptans, it is useless. It doesn't work because the chain reaction is already started. In the release of chemicals and the chain reaction of pain trigger is already started, it would not work. And finally, if the injectable drug have to be used, then you can use simple drugs like Perinom-Voveran combination or MCET-Voveran combination will also work equally well. And finally, there are some patients who do not respond to all these things and they are so bad and they are hospitalized. Then now this one can use sodium valproate injectable forms, 50 ml diluted and use the infusion over a period of half an hour or so. So the 500 milligram can be used. So this is the format we could try, and more or less most of the headaches should respond to this kind of format.
Most neurologists prefer the drug naproxen or naproxen as the anti-inflammatory drug of choice for migraine. Though we also use Comuflam or Voveran, etc. But this you can try, and the dose that is usually used is not 250 mg but 500 mg of naproxen.